Hi, everyone, and welcome back. My name is Valeria De Luca. I'm Associate Director of Data Science at the Novartis Institute for Biomedical Research. And I'm very happy to be here today to moderate this panel with Emilian and Edward on how AI and more generally technology can help health to reach the unreachable. So hi, Emilian and Edward. Let me introduce you very quickly before we start. Emilian Pope is founder and CEO of Elara Health, who's making common diagnostics more accessible and affordable to people in Africa. Emilian has a lot of years of experience as an investor entrepreneur in tech industry and with a special focus on Africa, and he's really passionate about prevention and early diagnosis of diseases. So welcome, Emilian. Edward Booty is founder and...
Thanks, Valeria.
Hi. So Edward is founder and CEO of Reach52. Their flagship healthcare platform allows to access to a variety of healthcare services and is envisioned for low connectivity areas. Edward has a lot of experience in both public, private, but also non-profit healthcare organizations and has worked in a variety of healthcare fields from digital health to business development and patient access. So hi, Edward. Before we start, I just want to tell also all the attendees, feel free to add your comments and questions on the chat, and we will check it towards the second part of this panel. So with no further ado, let me kick off with the first question. We heard also from Aisha earlier how data is actually at the basis of every AI application. And we all know that collecting data in healthcare is very difficult for a lot of reasons. So what do you think are the key technical requirements, but also challenges when we acquire healthcare data? And also, if you can comment as well on the differences between rural versus urban areas, and if we really have to prioritize, what is the key type of healthcare data that we should collect? Edward, do you maybe want to start?
Yeah, sure. Well, firstly, thanks for the intro, Valeria. Thanks for the invite today for the event, and lovely to meet you, Emilian, as well. So yeah, Reach52, we do train health workers in rural areas to provide healthcare access. We have about 5,000 health workers trained in 5 countries in Asia and Africa now. Technical challenges for us, no internet. Our application works fully offline. Old versions of Android, we have to support Android version 4.4, which I think is about 13 years old now. Low digital literacy, designing very simple screens that aren't necessarily the sexiest in the world, but are very functional in terms of how to really just make the ask clear. Is probably some of the biggest, app-based challenges that we face. And I guess to answer that second point very quickly, then perhaps we go into detail. We actually did start with about 60 or 70 health data indicators that we collected up front. So yeah, we launched in a community, we trained the health worker, and to really understand the needs prior to launching any, screening campaigns or interventions, ask each resident 50, 60, 70 questions. Across, height, age, weight, current diseases, medicines, income, and yeah, people got bored. They switched off. They gave bad answers. They just, get out of my face sort of mindset. So we've cut it down to about 10 now. It's sort of, are you pregnant? Do you have any children? Any of these diseases? Any family history? And I'd almost think of that as the metadata or the macro data about a person. 5 to 10 minutes to sign somebody up. And then subsequently, you can drill down into those deeper areas based on actual need. So yeah, happily go into that in more detail, but we've got it down to about 7 sign-up questions that we think are the most important indicators that sort of drive future programs, interventions, personalization and such. And I'll pause there, but welcome any more questions on that.
Miriam, maybe do you also want to add anything from your side or comment on data collection?
Yeah, absolutely. So I'll give my perspective from Kenya, for example, where we operate. So most of the care in sub-Saharan Africa is delivered through primary and secondary care medical facilities, and they're super fragmented, extremely fragmented. There are 15,000 nurse-run, nurse-led, 1 or 2 rooms medical facilities in Kenya, where 90-something% of the care is delivered. You compare that to, let's say, 700 or 800 proper hospitals in France or UK or somewhere else in Europe, right? So super fragmented. 9 in 10 do not have and are pen and paper, don't have any systems. There's no EMR, no EHR, nothing. So in a world like this, it is very difficult to collect data when fragmentation, lack of technology. So even if a medical facility has some kind of data collection system, let's say an EMR, basic EMR that they use, we've seen we are in about 500 facilities with 1 or more diagnostic devices out of those 15,000. And again, half of the 50,000 are private, half are public. So it's also the difference here. The difficulty comes from a public system which doesn't have any kind of any systems at primary care. It's even more difficult. But let's say out of 8,000 private facilities, we're in 500, 9 in 10 have no systems, and most of the disease areas covered are very simple things: upper respiratory infections, digestive infections, some cardiac diseases, and maybe malaria, HIV, diabetes. So even if they were able to collect data, the data sets would be very limited. So there's little, it's very difficult to get pure, proper longitudinal data sets for these data sets to be usable, unless there is a push and there is a proper system to collect this data.
Oh, thank you. Thank you both. So, beside the, maybe lack of data or lack of kind of technical systems and platforms in the background, one thing that it's, there's maybe like a space for AI is to really upskill medical personnel, especially I imagine when there is a lack of very experienced or specialized medical doctors and a lot of care is left to nurses. And I'm sure you both have a lot of experience on the ground on that. So on the technology side, I'm thinking, about interpretable AI and so forth. But coming from really the business and the day-to-day, what do you think, what's the best way to allow AI to really upskill people to deliver better care? Who would like to start?
Yeah, I'm more than happy to start just as off mute. Well, yeah, firstly, really good question. I guess it probably is a thought process about running before you can walk in this sort of situation. As you rightly say, as was rightly said by Amelia, a lot of the health centres we work with, no EMR, no phones, they are paper-based. So obviously, yeah, everything starts with really digitising the health service, improving digital literacy, collecting clean, high-quality data, and really getting that foundation built before any other applications can be added, right? Whether that's basic reporting and charts and just simply reporting on what's happening, right through to your more advanced uses of data. I think, yeah, one of our biggest learnings has definitely been that effectively, health workers don't want to use the tech. They've done their job without it. They use paper. Yes, from an external perspective, it would be nice to have digital solutions, but often, paper is known, it's familiar, it's easy, and it works, I guess, for them in terms of their role. And how to change that? I guess it happens over time. The digital maturity of communities is improving, Facebook and everything else is increasing, and therefore, broadly speaking, people or populations are becoming more digitized. That happens over time with increased network connectivity, wealth, income, ability to buy phones and such. And then that would knock on to healthcare. So part of me thinks it will happen. It's just a matter of waiting for digital services to penetrate more deeply. But in terms of how to actually really implement, really get people on the ground to use it, and then what's the best way for it to be used, I think it's down to, firstly, just the design of the application. Whatever you're doing, make it user-centric in a low-resource setting. Picking up something from America, some super shiny AI app, dropping it into Cambodia, rural Cambodia, it's just different. The way people need to consume tech and the interface and the whole design, it is different. So firstly, anything you build, design it with this context in mind. Lifting and shifting stuff just isn't going to work. And then core applications, yeah, it has to be, for me at least, decision support. As was rightly said as well, hugely fragmented health systems, bad patient experience, community health workers, nurses are the first points of contact. Let's just imagine I am that nurse in a rural health center in Kenya or Philippines or Indonesia, pick a country, and I'm supporting 1,000, 2,000, 3,000 people. That's my job, and I've got a phone in my hand. What can I do? I'm not a doctor. I have to refer people. Then there's public, private, pharmacy, all these different fragmented services. So in my view, really having any sort of AI, ML, automation around empowering the health worker on a sort of foundational tech skill to help refer people to relevant services, to almost provide that sort of integration point and front door to everything else, and really sort of giving them that knowledge in their hand would be where I'd probably see the most use. But again, that's not going to happen overnight, and it's certainly something that we all have to work towards as a digital health community, I guess, in low resource settings.
Yeah, definitely. And I imagine, so basically it's about listening a lot to all the stakeholders and users and patients, being embedded in the local territory, understanding the ecosystem, and then, yeah, this is basically the foundation before we deploy an AI system that maybe won't even be used. Oh, thank you. Emilian, what do you think?
Yeah. I mean, look, I'm a big believer in upskilling or upgrading humans using technology, and there's a big debate whether or not in medical the technology should or can replace a human doctor. And I strongly believe that a human needs to be there. Mainly in a medical, it's a lot of relationship between a patient and a human, but that human can be upgraded or upskilled, mainly in places in the world, like in Africa or parts in Africa, where most of the care is delivered, as I mentioned earlier, as Edward accentuated as well, delivered by nurses, by lower skilled medical personnel, who may have very well intended to deliver better care, but they don't have the knowledge. And we look at, the data shows already that there's a massive number of cases which are misdiagnosed, and mainly as soon as you get into more complex things. So maybe a basic flu is detected, but anything above that is complex because of the lack of knowledge. And there are a couple of ways technology, AI or not AI, but technology can help. And one is clinical decision system, and that's a typical AI powered tools. I've seen a couple of good ones, such as Ada Health, it's a German company, Babylon with Babil in Rwanda. So there's clinical decision systems which allow a non-skilled or low-skilled medical person to detect properly a certain disease, so with a really good specificity and quality of the decision. The second part is and specifically on diagnostics, because that's what we do. Well, on diagnostics, we've seen massive now influx of AI-based and technology-based either blood test machines or imaging, ultrasound, X-ray, MRI, where the AI is much better than humans, right? The image analysis, or even in hematology, so in blood analysis. Today, we can do hematology, and there are a couple of companies in India and Israel. They can do a full blood count just using image recognition, so identifying the red blood cells, the white blood cells, the hematocrit, and the other parameters of a full blood count. And so definitely in diagnostics, in a world where a blood test is in Nairobi or in Kenya is as expensive as in London or New York or Paris, it's impossible for someone who makes barely $100 a month to pay for a blood test. And we know that half a billion people in Africa can't afford or access even a simple blood test. So that's where AI is definitely used. It has a massive implication in rendering the diagnostics cheaper and better. And then the earlier presentation on cervical cancer actually is just something which is very, very close to my heart, because we've been looking at how can we bring technology in cervical cancer detection early detection. I think this is a great solution.
No, thank you. So, because in the audience we have a lot of also, young machine learning engineers and researchers. If I want to stick to this topic, basically of, really presenting like the output of an AI system to clinicians or even patients or healthcare providers. I mean, how should they design it in the sense of how to propose the output? So we've seen, also like big tech proposing this, as you mentioned, the disease detection from imaging, and we see kind of a not so often adoption, even in the Western world, where maybe radiologists are used to, use automated system and so on. So what should they think about, or what should they prioritize when they design this system, like as hands-on engineers, and then present them to their customers?
Yeah, it's a really good question. I mean, well, firstly, yeah, Practice 352 also worked, tech consulting in the UK, telehealth, trying to get, incredibly good digital innovation for the UK health service that bluntly people didn't want. So completely near the point that for all the amazing tech in the world, often it just doesn't get adopted because clinicians or patients, for whatever reason, don't want to do it. Working in emerging markets is no different, I think. Even though there's need, even though there's logic, it doesn't mean that something fantastically brilliant and logical gets adopted instantly. I think for me, I don't think there's any rocket science in this. It's about, as you said earlier, it's about being close to users, being close to doctors, designing with them, starting with the problem, working back, iterating, and not just starting with a solution or a tech product and then looking for the problem. That's what effectively happens a lot of the time. And we've certainly been guilty of this, or fallen into this trap of, simple example, here's some paper, let's digitize it. Health workers don't want to do that. It is easier for them, to do paper. They don't have phone, they don't have the internet, they don't want to do that as a pain. They haven't done it for the last 20 years, whatever it is. So even for the most basic tech applications, you have to consider that. And when you actually, think about how we solved that, as I say, it was just down to the design. It was, we made an app that didn't work. People didn't want it. There would say 10 questions on the screen. We realized that one question per screen made it more friendly, for example. And then, you build from there, and then you can add more questions from there. So I don't think there's anything, rocket science here, apart from design with the user, start with a real problem and work backwards. I think what it's worth just adding to that, and I didn't add it on my last point of real, usage of AI, usage of ML. Definitely think clinical decision support, task shifting to the front line, empowering frontline health workers is the key one for me, at least from where I'm sitting. But also, linking to the points that Miriam was making about, just limited resources. A lot of people can't afford stuff. Health systems have limited money. I think there's huge work to be done in terms of understanding personas, understanding who is health seeking, who engages with care, and then using any sort of automated data-driven tools to help resource allocation to where it's needed most, right? Because if you imagine there's lots of users, lots of data, I might be Edward, I'm 33, male, blah, blah, blah. I consume health services in this way, and that's how my persona consumes health. How do you then target people like Edward with other relevant health services to maximize the limited resources you have, and personalize and indeed bring some public health services into the modern era. So some of these sort of use cases where it's helping allocate incredibly scarce resources either from the government or from patients individually, and bringing in personalization, high quality, especially at the back end, I think will be really, really valuable from my point of view.
Thank you.
No, absolutely. I'll just add to this. So I think simplicity of the data collection is very, very important. I mean, we live in a world where we said that Africa has the biggest number of smartphones per per inhabitant, but the reality, the use of those smartphones are very, very difficult than you and I. They're very, very different than you and I would use a smartphone. So that the cell phone data is still expensive for those people. So they may have a smartphone, but they don't know how to use the full capacity of the smartphone. They don't use the data besides very simple WhatsApp or Facebook. So something which is very, very simple. It needs to be something which is very simple for the clinician to collect data. I think that's number one. And really number two is the concept of a annual checkup that we're used to, and where a patient or a doctor will be able to collect complete data sets of biomarkers from a patient does not exist in 95% or 97% of these populations. So when you may know that a data point from a million, let's say a malaria test, or a data point from Edward, let's say a cholesterol test and something else, and then this doesn't help. And despite the fact that you can collect some demographic data on those people, you still need to, I guess, from a medical perspective, you still need to collect complete data sets to make use of these data. So the question is, how do you get there? How do you collect these data? How do you bring insurance players, payers, different payers, pharma companies who can, subsidize or pay for data sets? Data protection is very, very important. So, we may not think that, in Africa, this is such a big, such an important thing in poor population, but those people understand that data is theirs and understand that the medical data belongs to them. And we need to, this needs to be done in a very, very, professional way in terms of the way we collect the data, the way we do not, share anything related to names. So it's just anonymized data. So those are a couple of things come to my mind, and things which we face, we face every single day in the work that we do in those very fragmented medical spaces.
Yeah, no, absolutely. And so personally, I come from the pharma world, and we also see that actually a lack of data coming from African population is also hindering the applicability of our developed drugs in the huge diversity that exists in Africa. So it's a very important point that we really need soon this data to be collected. So guys, go back to work. Yes, please.
It just popped into my head as Amelia was speaking. I guess, how do you get businesses or governments to adopt, modern digital data or AI, ML innovations? The way I'm trying to think about it now is, does it add cost or does it help relieve cost, right? Because let's just imagine, me and Amelia collect the best data in the world. We run some fancy AI algorithm and find lots of patients with diabetes and cancer, something like that. Great that we've sourced them, but there's not enough money to pay for treatments. Even with a very limited pool of treatments right now, we haven't found all those patients. The system cannot afford those treatments, right? That's the reality. So that's sort of a great innovation that adds cost to the system. On the flip side, if we had lots of data, we task shifted, we stopped diabetes, we prevented diabetes from incurring, more of a prevention play. That's clearly better, because then you don't have enough treatments and then you're stopping people that need treatment. So again, perhaps a way to think about governmental or low resource setting adoption would be to think about, does the innovation drive up the need for more spending where there simply isn't enough money, medicines, resources at the moment? Or does it effectively task shift to enable prevention and cost savings, I guess, would be perhaps how I think about it as well, if I was smart enough to do data science and AI, ML stuff, which I'm not.
No, absolutely. So basically prevention would be a focus to keep in mind, because that might be the best also to apply for these realities. Do you mind if we switch a little bit topic? So again, because we have a lot of young people in the audience, we see a lot of applications emerging in the last years, especially focused in Africa and AI, in the field of healthcare, like detection of fake drugs. We see image-based or computer vision-based diagnostic tools, your healthcare platforms that are really helping data collection and delivery of care. A lot of portable and automatic diagnostic tools and so on. So there are a lot of possibilities. We saw prevention being a very important topic as well. But if you think in the next few years, 2 to 5 years down the road or even shorter, what would be the killer app for realities in Africa?
I'm just processing. It's just one killer app. My answer is still the same. Anything that empowers frontline health workers to be more like a doctor. There is chronic shortages of doctors and specialist health workers. Even if we invent 1 million more doctors tomorrow, they're still going to centralize in cities, not in rural areas. The one constant fact, I care about rural healthcare, right? The one constant and actually available resource is community health workers, nurses, and such. And yet, even if more doctors are magicked up tomorrow, they're still going to be going to Nairobi or Manila or Jakarta on average, right? So yeah, anything that empowers them, allows them to make better decisions, shifts care from the cities to the communities is just essential. And it's sort of impossible to say that's like a AI blood pressure monitor or something. It's not about that sort of specific intervention in my view. It's just about that conscious, holistic shift of care to people in communities, because that's just the realities of what's going to be needed to enable health for all. So yeah, that'd be my view. Don't know if that's the right answer, but that's what I could really say on that.
No, absolutely. And look, there's a big discussion around the super apps, right, in Africa, and then the kind of the Ubers in transportations or the whatever are there. And I think I doubt that in healthcare a super app will work, because it's a very complex healthcare, much more complex than moving people from A to B or moving money from A to B, like the M-Pesas of the world. So healthcare is a complex thing, and we talk about technology only solutions in places where either there is infrastructure, so the developed part of the world, there's the infra is there, so you develop a piece of technology which taps into the infra, great, or where you don't need infrastructure, so moving money, transferring money, M-Pesa, you don't need banks, right? You can do it just digitally. But in healthcare, the home-based care in those settings, it's just very difficult to happen, right? So remote patient monitoring, things that we see in the developed part of the world, I think is going to take a long time. So people will still need to go to see a clinician. And really the solution is, I think, is way over and above an application. The solution is actually to upgrade both from a technology and infrastructure and diagnostics and medication and the fake or detection of the fake medication that you mentioned, to upgrade the super broken primary and secondary care, where care starts, and upgrade this infrastructure from a technology point of view, education point of view, physical infrastructure point of view. And that's where it's going to really change. So I think just one piece of this ecosystem is not enough. It's the full the upgrading of the full ecosystem which is necessary.
Thank you. So we're getting some questions from the audience. I'd like to read out loud one. I think it's very interesting. So how do you incentivize users to keep using the tool after deployment to take ownership? One thing is quite often is that data is being taken away from the communities, locked away in some database, and are difficult to access. And maybe easy access to data for those communities would encourage ownership. I think it's a very important point of view.
Yeah, I couldn't agree more. Like literally spend money, I've talked about that exact thing twice today. 100% correct question to ask. Yeah, 100% true. As mentioned before, we used to collect about 70 data indicators up front. Bad idea. Just don't do that. We go for a small amount of, the minimum viable data to understand needs and then work from that. Then we know perhaps you have diabetes, and then perhaps you're pregnant, or you've got a young child, whatever it might be, and then we look to deliver interventions in that space. So it's a small amount of data for an intervention, but then we're doing something in maternal health, and while we're there, we're giving you something effectively, a service, and you give a little bit more data, or you ask for a bit more data, or ask for relevant questions to help understand people's healthcare needs. So I think the answer for me is, yeah, don't go for big data collection up front. It has to be incremental, and then link it to actual service delivery so people see actual value. And then at those future encounters, capture a bit more. So we always call this levels in Reach 52, levels of data. And it starts with level 1 and goes to level 4. And that's sort of married to our service delivery model, I guess. Yeah.
And I would,
sorry to interrupt.
I would add to this.
So Emilian, can I give you the last question before we wrap up? So there is another comment. Can junior machine learning engineers who don't have a background in the health field work in health tech? And because we don't always understand the data we are dealing with, so because you worked a lot as an entrepreneur and founding also health companies, health startups, what would you recommend?
No, 100%. It's just I would love to have access to junior data science and data engineers and then work with those individuals, either remotely or in Kenya or South Africa where we are. So it's just, I would say, my advice for data engineers is to link up with companies like ours, like Edwards, like our company, like other players. The operators, right? People who collect data from the field, data through a B2B model like ours, or through a B2C model, or and then work, because there's so much work to do. There's such a big opportunity, as you said. There's such a Africa is the most diverse data mining opportunity because of the different populations. It's just identifying those companies and then work with them. Glenn, feel free. I would say my contacts are out there. I would actually love to speak to everyone who's interested to work with us.
Great. So last 30 seconds. Pick 3 words to describe what do you think about AI and health, the current status in Africa. Who goes first? Not ready?
Thinking. Yeah, I guess it would be walk before running. Yeah, there's no point. I mean, even with Reach 52, I had all these fancy ideas for what we'd like to do with data and how we could enable health for all with data. Fundamentally, people often don't use phones. There's no internet. There's no data. So, yeah, be aspirational, but walk before running would be my 3 words.
I would say collect, complete, analyze.
Okay. Yeah.
Cool. Okay, I can share mine if you want. It would be exciting, local, and definitely democratizing. So thank you everyone for joining this session. Thank you so much, Emilian and Edward, for your input. And we'll reconvene in a little bit with the keynote speaking.